Okay, good afternoon. Welcome to the board's May 7 and 8, 2019 board meeting. My name is Victor Law, president of the board. As I call this meeting to order, I would like to advise all members of the public, both present or watching the meeting's webcast, that the board is a consumer protection agency subject to the Opening Meetings Act. Members of the board may be using an electronic copy of the meeting materials. Please be advised that such members are using their devices for this purpose and are not communicating with each other via email or other electronic means. I would like to remind everyone present who is interested in receiving continuing education credit to remember to sign in and out on the designated sheet in the back of the room. This meeting is being webcast. We respectfully request that when called upon to speak, please come to the speaker's table and speak directly into the microphone. This will ensure those individuals watching the webcast are aware of all discussion and actions. As indicated on the agenda, the board will convene in closed session. Upon conclusion of closed session, the board will reconvene in open session and will adjourn the meeting in open session. This portion of the meeting will not be webcast unless the board will consider any other open session agenda items. And I thank you all for attending, and I look forward to a productive meeting. And now I would like to take a roll call and establish a quorum. Let's start with the right-hand side from Albert.
Albert Wong. Albert Wong, professional member.
Lavanza Butler, professional member.
Ricardo Sanchez, public member.
Valerie Munoz, public member.
Alan Chad, professional member.
Greg Lippy, public member.
And I'm Victor Law, professional member.
Maria Serpa, professional member.
Debbie Veal, professional member.
Stan Weiser, professional member.
Okay, thank you everyone, and a quorum's been established. Let's move on to agenda item number 2, which is public comments on agenda items for futures meeting. Now, with the quorum being established, I want to remind members of the public that the committee cannot discuss or take any actions on any matter raised during this portion of the meeting, except to decide to place the matter on the future agenda. So if anybody wants the items, public comment for future item on the agenda, please come up. Come on up, Steve.
Thank you. Steve Gray, individual pharmacist, on behalf of also CSHP. I would like to comment that the last year's meeting of the Enforcement Committee in December was very well done. And by that I mean, not only was it well done, but it was very timely. And I would like the full board to establish a policy that says they will have an Enforcement Committee meeting, after all the bills are signed, but before they go into effect, so that the board members themselves all have a chance to comment and discuss board policy on how the new laws or enforcement procedures are going to go into effect before there are cases after January 1 when the board then couldn't discuss them. And I noticed that the Enforcement Committee meeting did not have a scheduled meeting in November or December, and I would like to suggest to the president and so forth that maybe he schedule that for this upcoming year. Thank you.
Take that into consideration. Thank you. Good afternoon, Paige.
Hi, good afternoon. I have 2 issues. One is piggybacking on what Steve said. Sorry, Steve, but this is late.
Mic on.
Yeah, it says it is.
Yeah.
Really? Okay, now you can hear, right? Okay, for Assembly Bill 2859 by Assemblymember Caballero was passed last year. It has to do with the safe storage containers. We, of course, were opposed to it. I think many people were opposed to it. But it passed, and it did have an exemption for pharmacy, pharmacies, if you owned less than 4 or less pharmacies, you were an independent owner, or and you had to also own the majority of the pharmacy and manage it and work in it. Well, there are closed-door pharmacies. They don't open to the public. I'm curious to know how that's going to be enforced. Do they still have to have the display of these bottles, locking bottles for C2 through 4, even though the public doesn't come into their stores? And that's long-term care. That's, I always mispronounce this, radio pharmacy. There are many pharmacies that are closed door. Patients do not come in to their stores. So is that going to be enforced or not? I would like that on an agenda item.
Yeah,
As
we'll have the enforcement committee take a look at that for you.
Okay, and then for compounders, there was no exemption for compound. Caballero was very strong in wanting what she wanted. And so that's a concern as well because of the kinds of medications they have.
Okay,
They're
thank you.
not usually tablets. Okay, so that one needs to be discussed. And then this really isn't in your purview, but it does affect patients. I'm not sure that you're aware, and I wasn't aware until recently, that nurse practitioners must have to prescribe, they must have a furnishing number, and it's through the Board of Nurses. And that number is supposed to be on a prescription. Nurses typically don't even know what their number is, and in long-term care, they don't see that prescription. It's paid for. They deliver the meds to the nursing homes or the residential care facilities, wherever. And then during an audit, a PBM can say, oh, well, there's no nurse practitioner, NPF number is what it's called. There's no number on this, so we're going to reverse that claim. You don't get that money. And so that's an issue that I'm just hoping that maybe it could be discussed because patients in a community pharmacy, well, they're all community, but you know what I mean, retail, they can look at it and say, oh, we're not filling this prescription
It's
because
printed.
it doesn't have the
It's printed.
NPF number.
Yeah.
But in long-term care, they can't do that. So I'm going to go to the Board of Nurses, and maybe the Department of Managed Health Care, but it would be wonderful to have support from the Board of Pharmacy as well for that, because it is an issue. Many of my pharmacies are having to pay for drugs in the end down the road when they get audited.
All right, thank you.
Okay? All right, thank you.
Blake, please come up.
Good morning, Art Whitney, pharmacist. I have a lot of issues, but probably one that you can help me with. I'd like to have on the next agenda someone that could explain Article 4 requirements for prescription, Section 4071.1. We recently had a inspector provide us with an interpretation that I do not believe is correct.
What is that item about?
Well, it talks about, well, if you want a few seconds, I'll tell you what happened. So it says, yeah, that's the case.
Yeah, I know. Wait.
What is that?
Well,
Tell us what happened.
no, okay, yeah. The citation is a prescriber authorized agent, or a pharmacist may electronically enter a prescription or an order as defined in Section 4019 into a pharmacy's or hospital's computer from any location outside the pharmacy or hospital with the permission of the pharmacy or hospital. The purpose of this section is prescriber authorized agent is a person licensed or registered under Division 2. This subdivision shall not apply to prescriptions for controlled substances classified Schedule 2 through 5, except as permitted.
This is an enforcement matter.
Yeah.
Yes, yes.
Well,
Yes, enforcement,
we-
yes.
We could refer that to Alan to tackle.
So I would actually recommend, Mr. President, since it's an open enforcement matter, that maybe you encourage the speaker to speak with your interim executive officer and see if maybe there's some,
Yeah, they could
Value to
issues
that
that could be
conversation.
resolved.
Okay,
Okay,
okay.
thank you.
You need a copy of this? Anybody?
Okay. Okay. All right. Thank you. All right. Any other matters? Seeing none, we'll move to agenda item number 3 is the approval of the January 30th to 31st, 2019 board meetings minutes. Board members, are there any comments or any corrections?
I'll make a motion to approve all 3 if we can do that.
Uh,
Thank you, Ricardo.
I have one over here on page 6 of 48.
Which one?
Page 6 of 48, item number 2, under that AB 1753 low, on the first paragraph.
Which month is that?
January. We're talking about the January minutes. Page 6 of 48, the first paragraph, the last 2 sentences. It says, Mr. Shedd stated in response, Ms. Harrow suggests enforcement's discretion. There must be a typo. That was typo, right? Okay. All right, and then it says, Josh support the executive officer's opinion. So we only have an interim executive officer.
Well, whatever it was, I'm sure I supported it. You did it eloquently.
That's a typo, so just to clarify that, okay. And I think that one, without that one, that will be okay. All right, public comment?
Yes, thank you, Mr. President. On the January minutes on page 38, I am listed as saying I'm against the advanced practice technician licensure, and that is 180 degrees wrong. I'm not against
It's not against.
the advanced practice technician category.
Okay, all right. It's another second amendment. All right. Stan, is it okay to motion to approve as amended?
Thank you.
I need a second.
Ricardo, yes.
Second by Ricardo. Any other discussions? Public comment? If not, all those in favor, please raise your hand. Okay. Abstain? No? Okay. If you abstain, you got to vote? Is that okay? Okay, and the minutes are approved. Shall we go on the next agenda item number 4 is approval of the March 22nd, 2019 board meetings minutes. Board members, any corrections,
So my
amendments?
my understanding is that the motion, and
Yeah, we
perhaps
just-
we
the
need to
motion was
revisit,
for all
I think
three.
the motion was that
All
all
three?
3
Oh, okay.
changed.
All right. In that
But
case,
if
we'll
you
do 3, 4,
reconsider,
and
you
5 all together. Okay. All the minutes are approved. That's a shortcut. All right. Then let's move on to agenda item number 6, recognition and celebration of pharmacists licensed in California for 50 years. And I understand that we have 2 members here present. All right, good. It's like karaoke. Okay, all right. I could do that. Okay, first person is Jin. Please come up. And you have your wife with you? Yeah, you could come up together, please. Yes, come on up. Okay, please introduce yourself and your family members, and in a short time period, describe about your life story. We have only 5 minutes.
Okay. We face that way? Okay. I'm Gene Tsukamoto, and this is my wife, Cynthia. And we've been married. 50 years. I can remember that because this is my 50-year anniversary with the board, and it's 50. We've been married 50 years, so I keep track that way. It's been a wonderful profession, and I can remember when I first started out, I was making $9 an hour in Central California, and I thought, I was going to be rich. That didn't turn out that way. A few years later, we started getting raises, and I sort of felt guilty making so much money that I started donating freely to a lot of causes, and we still made ends meet. So it felt good to share the wealth and all that the pharmacy has afforded us. And now that I'm retired, semi-retired, I retired 5 years ago, but I send my days that I'm available into Rite Aid, and if they want me, they call me. If they don't, it's fine with me. And it turns into a good chunk of pocket change that helps ends meet. So we're still enjoying fruits of our labor. Cynthia has put up a lot. I owned a store for 14 years and practically lived there. She raised the family by herself, and then sold out to Save Mart and went to work for Save Mart for about 15 more years, and then left there and went to Rite Aid, and I've been with Rite Aid for 15 years, so that's 45. There's a few years in between there that you fill in the spaces. I attended the pharmacy board meeting when I was in pharmacy school, and our instructor, Carl Vitale, I don't know if...
Oh, yeah.
Okay, well, you remember. Okay, good. Yeah. He got me to, after I graduated, I got on with Save-On, and then we moved to Central California and opened my pharmacy. I don't think it was part of a requirement for the class, but he encouraged us to attend a pharmacy board meeting. And at that meeting, there were pharmacists that were, men that were older than me, in tears, begging that the board be lenient on them because they, messed up somehow. And it made a big impression. And I think, I don't know if you have pharmacy schools come to your meetings?
Sometimes.
Oh, it's a good, worthwhile class or come here and see what happens when you're being run to the ringer, and kind of set your mind straight to what's required of you and what you don't do and do. So that was a good experience, and Carl, when he signs his name, has a big C, and he wrote a little H-I, hi, to me. That's a special license. He signed it just for me. Okay. I think I've taken up my 5 minutes.
Okay. So on behalf of the California State Board of Pharmacy, I'd like to present you with this pin to congratulate and to thank you for your years of service. Thank you very much. We have a second person. Please come up. Welcome. So please introduce yourself.
Hi, everybody. I'm Donna Ochita, and I've been a pharmacist since 1967, and I've worked for only one company, and that's Kaiser Permanente, and I think they're the best. And I started as an intern. I was the first female intern at the San Francisco hospital, and the chief pharmacist asked me if I could move things like the guys do. I can do anything they can do. It just takes me a little longer. But I enjoyed my years with Kaiser, and in 1967, I was a pharmacist at Kaiser San Francisco. I only got paid $5 an hour. I was transferred to Sacramento because they needed help when they had the Sacramento facility open. I had to take a pay cut to $4.75 because the cost of living was less than Sacramento. but I lasted until 1997, so that's about 35 years, including my intern years. And so now my job is to travel the world. I've been on all 7 continents.
All right.
So,
Great. All right. Thank you. Let's take a picture here, right here first. All right. And on behalf of the California State Board of Pharmacy, I'd like to present you this pin to congratulate you and also to thank you for your use of service. Thank you very much for coming. And now, any more 50 years pharmacists? No? But right now, we do have one more person we need to recognize. This person is a very important person, and his name is Stan Weiser. This could be the last year, or could be the last meeting of his service to the board, so I want to take this opportunity now to recognize him. Now, let me tell you something about him first, if you don't know him. Now, he graduated from the University of Connecticut, and he came to California and opened his own pharmacy in 1969, and then he retired in the year 2000, and he was appointed to the board 2007. From 2010 to 2015, he served as the president of this board. Now, besides that, Stan also served as an executive member on the Redland Community Hospital, and he's also a trustee for the University of Redland. Now, during his term as president, he really demonstrated strong leadership in implementing the SB 493, along with other sterile compounding. The thing I really like Stan is he's a very straightforward, friendly person and very fair. The fact that he also works well with people, and he inspires everybody. Now, the first day I came to this board, I tell myself, I want to grow up and like Stan. Please come forward. On behalf of the board, we have something to present to you. All the board members here, we have a plaque present to you in recognition of 12 years of your dedicated service to the board and to the California patients. Thank you for your commitment to consumer protection. Thank you very much, Stan. Well deserved.
May I? Well, thank you, Victor. Always love to have a microphone in my hand.
You only got 5 minutes.
And there's a lot of people that I owe thanks to. And it was Governor Schwarzenegger who appointed me to the board, and Governor Brown. And thank you, Governor Brown. If any relatives are here, can relay my thanks. He reappointed me twice, which really, given the fact that I couldn't convince anybody that the R after my name stood for Redlands, Governor Brown was very open-minded about appointments to the pharmacy board, in particular me. And here I am as part of the team of Governor Newsom's, and I will stay as long as he would like me to stay at whatever his pleasure is. And I too want to thank a lot of people, and I want to thank certainly the staff here, Ann and Laura and Debbie and everybody else upstairs have just been wonderful to me. And there was a mentoring process that I went through with Ann and with our previous executive officer that really was fantastic. And I always appreciate them and appreciate how they've helped me through. This has been an incredible experience for me, and hopefully everybody behind me feels exactly the same way. It's really one of the highlights of my life. And I owe my thanks not just to the governors who have allowed me to continue here, but to the staff of the board. I also want to thank the legal staff here, certainly Laura Kelsey and Josh. They're just spectacular, and they've been such a tremendous aid to me and certainly to the board for the direction that they have, the tracks, I guess, that they have kept us on. And so, again, I say thanks. I'm here for it, the pleasure of the governor and fellow board members. It's really been a lot of fun, and it's been interesting. I think we all walk away from these meetings liking each other and respecting each other in spite of an occasional difference of view, and that's the way it should be. So I guess in the near future, Stan's Drug is closing up shop. And thank you all in the audience. Without your input and without your collaboration, we wouldn't get very far here. So thank you, Victor.
Just to add a couple things. Yeah. Stan, I just want to say also thank you for serving on this board. You've been a great mentor, I think, to many of us here. So I guess if you like what you see, that's a good thing because you mentored us. But I also thought that your years as president, you were an exceptional leader. You gave your heart and soul, especially when you're president, but even afterwards, you've given your heart and soul. We always know when you speak up, it's from the heart. You want the best thing for the board. You want the best things for the citizens of the state. And you're my hero. Thank you.
Okay, let's move on to the next agenda item is board officers elections. Every year at this time, we're gonna elect the president, the vice president, and also the treasurer of the board. So before we start the nomination process, I want to say that last year was my first year, and we have implemented a few changes, and I really like to see things been going, and I really like to have a chance to move on and do one more year. But then also I have a good friend of mine, Greg. He has served many years on this board, and I'd like to see him going out as the president of the board. And so it's like a very big dilemma here that we try to serve two purposes at one shot. I want to run by the board members if we could have an idea or motion that we could both serve as co-president of the board for this year, so we both could do two things at the same time.
Yes, I would like to make a motion that we have a co-president, Victor, and Greg as a co-president. I will make that nomination.
So I think, unfortunately, your statute doesn't contemplate two presidents, and then the board organization doesn't anticipate that. So I think that's going to present some logistical issues of who's making the decisions that are vested in the authority of the president, both in 4002 of the BMP, which is part of the pharmacy law, as well as like when it comes to cease and desist authorities or something like that. Those powers are vested in a single human, and if you have two people in that position, I think that would create a conflict. So I would not recommend that you have co-presidents.
Could
And
we
the board-
delegate one person to do it?
And the board cannot suspend that. If the board itself
statute.
to do like every co-chair it or something like that.
Certainly, if you choose a president, the president could say, when the president isn't available, that's when the vice president would step in and take over or perform those functions. That could be done, but there's still one person in charge. And the other concern that I might have is there might be an Open Meeting Act problem if you have two people who have powers, and it's a collective decision. So I think there needs to be one person in
So
charge.
can we have two co-president, but if Greg willing that he could let Victor make the decision as the president.
I'm not sure I follow. Can you explain a little more of what you had in mind?
Yeah, well, what I'm saying is that they could be co-president, but in title, and then Victor will be the president who make the final decision.
I would suggest that if one person's making the final decision, then that person is the president.
Is there any regulation against it?
Well, I think the statute says that there's a singular president. That's what 4002 says. It says the board elects a president, not multiple. So
But it doesn't disallow a co-president, though.
We've always set trends here.
I've given my advice.
I mean, in also Open Act, isn't it more than two? Could be the Open Act violation. It's just, or you're just two persons. Would be an Open Act meeting.
Two people with
More than two, right? Or just two.
So if the authority to make a decision is vested in more than one person, not an advisory decision, but an actual decision. So for example, appeals of cease and desist. So a cease and desist order can be issued by the executive officer. That can be appealed to the president. The president conducts the hearing, can be delegated to a vice president if the president's not available, because basically the vice president does anything that, if the president's not available. But if you have two presidents, the question is that those two people would then have to make that decision.
We could decide among ourselves who
Yeah.
would be the one preside on that meeting. There would only be one person.
We could make that decision
work out
as
with Greg on a lot of
we
things
could make the
that-
decision which one will make the
Me
decision.
and
final
Greg could work
decision.
out a lot of things. We could share alternate meetings. We could share duties. We could delegate among ourselves. I mean, I know it's creative thinking, but it is something that it doesn't disallow either.
The statute says that there's one president. If the board, that there's not a consequence, but I think that it might create some confusion for staff when you're trying to follow up. If the board would like to say, carve out duties,
Right.
and say the president shall do these duties, and then the vice president does these duties, then you could do
What are we
that.
trying to preserve here with two presidents, co-presidency? I'm not quite. I understand I understand the desire to continue an agenda if that's what somebody has in mind, but I'm not quite sure. I mean, two presidents for the same organization, 13 people. I mean, it's really, I'm not quite sure if it accomplishes anything. To me, it seems to just complicate a lot of stuff. So I think the board over the years has had a single president, as all the other boards have, and it seems to me, from a leadership standpoint, it's a positive way to go. It's certainly a traditional way to go. And I think with staff and with everybody else, we have a president who makes certain decisions and determinations, runs meetings, and works directly with staff, and a vice president who would step in the event that the president wasn't available to perform the duties of the president. But to have a co-presidency, I'm not quite sure if it brings the positives of leadership out. But that's I'm sorry,
Well,
I'm sorry.
Okay.
Let's just go ahead, have the vote. Whoever
Right.
wins is fine with me. It isn't going to affect my friendship.
All right. Just open for nominations in that case.
Well, I would nominate Greg. I'm
but
under the impression
but
that
but hold on a second. But we did not finish on the last nomination. So can we discuss a little further on that? Now, if Greg willing to,
I'm not willing.
you're not willing to.
No, let's just go ahead and do it. It's causing too much issues.
Can we do
You
silent
know,
vote?
I mean,
Because-
we're both going to survive no matter what.
So in that case, since
You go ahead and nominate.
since last year, Gray and Victor have done such a good job on promoting the profession and the consumer safety. I would like to nominate Victor as the president and Gray as the president. Continue to serve the same as last year.
All right, nominations moved by Albert, and anybody second?
So just want a clarification on the motion. It's for Victor for president and Lippy for vice president, correct?
Yeah, Gray is the vice president. Victor is the president.
That's his
I'll second that motion.
I'm sorry. Can I just get some clarification?
Oh,
I think, so
Wait.
we have the nomination from Stan, we now have the nomination from Albert, but we're limiting it to the president right now?
It should just be one.
oh,
Does-
that's,
Can it be where we
President
do a
afterwards.
silent?
we'll do the vice president later. So moved by Albert for 1 second by Valerie, and then moved by Stan. Anybody second for Stan motion?
For Greg.
For Greg? Yes.
I'll second it.
Second by Debbie. Okay.
Can we do ballot like we do for the EO, or does it have to be?
Yeah, you gotta use your microphones, guys.
Okay. Can this have, when we voted for the EO, we did a secret ballot. Can we do that?
You cannot. This is an open meeting, and you have to do it. I do know that there have been in the past, because I think, I don't recall the board, and I'm looking to Kelsey to see if she remembers, because it's kind of a story in the office, that there have been cases where the members put their heads down and then raise their hands. But the public gets to see how you vote.
Oh, the public sees, but
It would find out anyhow, but yeah, it's an open meeting, and how you
Okay.
vote.
Any public comments? If not, we'll call for the vote.
but wait a minute. I'm not quite clear here. What are we voting?
Well, there's two nominated.
There, we have
They were
two,
voting for
we have
one or
two
the other?
nominations, and we'll,
Okay,
one or the other.
we'll vote for one of the others.
I'm sorry, a process question. So there was motions and seconds. So
Yes.
there's currently two motions on the table, as I'm understanding.
So
and
let's
you
vote.
give a little.
Let's vote for one at a time, right?
Well, there were nominations, not motions.
Yeah, there are two nominees.
The seconds weren't needed.
Yeah, there are two nominees, and so we just need to vote for. Okay, all right. For the first nominations, all those who want to vote for Victor as the president, please raise your hand. 1, 2, 3, 4, 5. Okay, 5. And all those who vote for Greg as the president, please raise your hand. 1, 2, 3, 4, 5. So it's a tie.
He promised to vote for Gray.
Yeah, well, no, they both can vote.
5 against 5.
That's why we say have a co-president.
All right.
Yeah.
Let's do a coin.
All right, what do we do?
Flip a coin.
Council, when it's a tie, what do we do?
Yes, so you can have further discussion.
Do you want further discussion, or you
So
have
it's
to,
obvious that it should be co-presidents.
but they wouldn't allow co-presidents, so
Well,
do we have to wait another meeting, or do we have to keep sitting here and wait until we have an answer? You want to flip a coin?
flip a coin. It's whatever the board. If the board puts forth a motion, flip a coin, and a majority of the board votes that the percentage of.
Okay. All right, let's flip a coin.
The motion that you guys flip a coin. They're both great. I mean, the code thing sounded great. I think it tears a lot of the board because we like both of them.
We
So-
need to borrow
Here.
an impartial
Here it is.
coin.
Okay.
Two-headed coin.
The two-headed coin.
So, sorry, really fast. So there's a motion to flip, but I think that that's going to need a second and a vote
Second,
first.
second,
Kelsey ought to.
I'll second that.
second, all right. Valerie, second that, okay.
So I recommend that the actual, I recommend that there be a motion and a second and the entire board vote on it prior to an
Okay,
actual.
all right. All those in favor of flipping a coin, please raise your hand.
We're all there.
Any public discussion?
Any public comments?
I think you're
If
making
not,
history.
all right. Stan, you have the honor, right?
Oh, God. No, let's have a non-board.
Let's Kelsey. Kelsey do the honor.
Okay.
All right, Greg, you called it. You want to call? Yeah.
Okay.
Uh-huh. What do you
Okay,
want?
who said who's?
Yeah, you want a drum roll for this, Kelsey?
All right, you call it. What do you want? You head for Greg.
All right,
Yeah.
good, it's over.
Okay, so I'd make a motion, I'd make a nomination for Greg Lippy as vice president.
I'll
All
second
right,
that.
Motion Greg as VP and second by Ricardo. Any further discussion? Public comment? All those in favor, please raise your hand. Oppose, abstain. All right, motion carry. And for the treasurer, you need a motion?
Motion to nominate Alan Shad,
Motion.
treasurer extraordinaire.
Motion for Alan, second by Ricardo. Any other comments, public comments? If not, let's call for the vote. All those in favor, please raise your hand. Oppose, abstain. Okay, motion carried. Congratulations, Greg, and congratulations, Alan.
Thank you, Mr. President.
All right, let's move on to the licensing committee report, and the chair being Debbie. Okay, Debbie, your turn. You don't have to cry.
You guys brought me to tears how you handled that. Okay, this is the licensing committee met on April 3rd, and the licensing committee consists of myself, Stan Weiser is my vice chair, Cheryl Butler, Amjad Khan, Alan Shad, and Albert Wong. So during the committee, during the meeting, our first presentation was on the medication-assisted treatment and discussion and consideration of a proposal to establish authority for pharmacists to provide non-opioid medication-assisted treatment. And we've talked about this in the past, but there's, I feel almost silly saying this first sentence, that there's a national opioid crisis. If anyone didn't know, I'm sorry. But one of the recommended solutions is to address this is to provide medication-assisted treatment to help wean patients off of opioids. And probably wean patient off of opioids isn't really the right thing to say because they truly have to be off opioids before they can go into these treatment programs. There are 3 drugs that are used. It's methadone, buprenorphine, and naltrexone. Methadone and buprenorphine are controlled substances and require a special waiver called a DATA 2000 in order to prescribe. And although our federal government considered issuing DATA 2000 waivers to certain prescribers, one of them, being a pharmacist, was not included. So the current authority, the current people who can obtain these waivers are physicians, nurse practitioners, and physician's assistants. So naloxone is a non-opioid medication that can be used for a MAP. And in Kentucky, pharmacists have been allowed to provide naloxone pursuant to a statewide protocol. The protocol, as our other protocols, state the criteria, the training, and whatever is needed in order for the pharmacist to put the patient on a naloxone treatment plan. So during our 2019 board meeting, the board approved a policy statement that supports the role of pharmacists providing drug care to patients with opioid addiction and to assist medical providers in caring for such patients. As such, the board's policy advocates for the changes in the law that would permit pharmacists to provide MAT as part of the collaborative healthcare team. So during our April meeting, we heard from, are you guys both here? Okay. We heard from Talia Zanian and James Gasper, both PharmDs. Talia is from CAC, James is from DCHS, and they presented actually a fantastic presentation. And I'm going to have them come up now. And what we've asked them to do is to come back and provide a kind of a condensed presentation from what we had on April 3rd.
Okay, good afternoon. Thank you for having us back. As I said at the licensing meeting, we're really thrilled and grateful that the board has prioritized the development of policy and is supporting advocacy for having pharmacists address opioid use disorder in California. So we're going to spend about 15 minutes going through just a very, very brief introduction of opioid use disorder, pharmacotherapy of opioid use disorder, but really focusing on pharmacists' roles, potential roles, and just really finish with ways that pharmacists can help expand access to medications for the treatment of opioid use disorder. I think there's been a lot of focus, as Debbie alluded to, that on overdose. Really, we've been hearing a lot about opioid overdose death rates for many years now, and that's because it's really striking, these numbers, and it's the leading cause of death for Americans under 50. It's the leading cause of injury-related death in the U.S. It's the primary driver now for reductions in life expectancy in the U.S. While these numbers are very alarming, fatal overdoses don't give a full picture of the entire opioid crisis. There are also the ED visits, the hospitalizations, the non-fatal overdoses, the medical and criminal consequences of opioid use, the toll on individuals and families, and really the toll on all of our communities as well. And so, very briefly, the scope of the opioid crisis beyond overdose, there are more than 2 million Americans currently that meet criteria for opioid use disorder. And in California, the Urban Institute's most recent analysis about a year ago, I think it was March or May of 2018, was that in California there's an estimated 350,000 Californians who meet criteria for opioid use disorder. And while I said we're going to move forward and talk about opioid use disorder, I want to say one more thing about overdose, and that's that map. In California, the average death rate ranks lower than average compared to the rest of the United States. The death rate in the United States is about 15 per 100,000 population. In California, the average is lower. However, if you look at some of those counties that have been highlighted, the ones that are darker orange and the shades of red, you can see that there are counties in our state, in the rural regions particularly, that are hit harder than the national average. And the reason we put this slide here is because in a few slides coming up, James is going to talk about the treatment gap that exists, that where people can't access treatment, and you can pretty much superimpose the maps. And that's because we know that treatment for opioid use disorder can reduce mortality by 40 or 60%. And so it's not surprising that the places where there's the least access would have the highest overdose. Opioid use disorder is a chronic recurring illness. There are evidence-based treatments. The standard of care is what we've called for a long time medication-assisted treatment. We're moving away from calling it MAT, or medication-assisted treatment, because just like in hypertension, we don't call it medication-assisted treatment. For depression, we don't call it medication-assisted treatment. It's medication treatment. And it's the same thing for opioid use disorder. Now we're calling it medication treatment or medication-based treatment, because it's really the medications combined with counseling, but even the medications alone serve a purpose and can improve a number of various outcomes. And it is the standard of care, as I said. However, more than 80% are not receiving treatment. This is one study. As Debbie mentioned, there are 3 medications that are used to treat opioid use disorder. One is an opioid antagonist, that's naltrexone. The other 2 are opioid agonists, methadone, or opioid partial agonist, buprenorphine. And the medication studies that have been done are usually one medication versus another medication. There are very few studies that look at all 3, and most of them are retrospective. This particular study is a prospective study that looked at all 3, and it was done in Massachusetts. And what they did is they took nearly 18,000 individuals in Massachusetts who had opioid use disorder, and they were opioid overdose survivors. And they looked at overdose survivors because prior overdose is a known risk for subsequent both fatal and non-fatal overdose. And so engaging these particular individuals may help limit subsequent fatalities.
Before you go on, I've got a question and comment here, if you don't mind.
Yes, of course.
I mean, this is kind of an interesting slide here, where you have all-cause mortality not decreased at all by naloxone.
Yes.
So could you comment on that?
So there have been some studies that have shown that naltrexone can decrease mortality or is as effective as the other medications. This particular study, even though there were like 800 patients in the naltrexone arm, you can see the duration. There are a couple of important things here I want to say. One is 66% of those 18,000 were not treated. So I just said that 80% aren't treated, so 66% is looking pretty good because nationally it's 80%. The authors really specified that in Massachusetts, their prevalence of insurance coverage is higher than nationally, and so maybe there was greater uptake. So that 66% no treatment is alarming. But it's even higher probably in California. The second thing is the duration of treatment, how long people stayed in treatment. You can see a big difference there with the naltrexone compared to the opioid agonist. And this is a real reflection of probably real-world practice, right? And it was real-world practice. It's hard to keep people in treatment with naltrexone, and I'll say why in a minute. But that duration may have had an effect on whether it decreases all-cause mortality or opioid-related mortality. So some studies have shown that naltrexone does. It's better than doing nothing. But the point of showing this slide is that treatment is not accessible. When it is accessible, it can have a really big impact if you can keep people in treatment. Okay.
And I thought one other thing that, and this was, there's the Vivitrol that I think the
naltrexone, yes.
Yeah, the drug rep was here during your presentation, and she pointed out that this study, the Vivitrol was not used.
It was used. So this study,
it was used? I thought
yes.
she pointed out it was not used.
So naltrexone comes in an oral form as well as
the once a month.
A monthly injectable. And in that particular study, they didn't separate out oral and injectable, but both oral and injectable were used. I would say, since this was a real-world practice, in the real world, most people don't use the oral for opioid use disorder. It's really used for alcohol use disorder. It's not as effective for opioid use disorder. The first bullet there, oral formulation is effective in very highly motivated patients or patients that have mandated supervised administration. So there are programs where the patient has to come in, get their naltrexone orally. These are very, very limited programs. So really the most effective way of using naltrexone, which is probably what most of those patients in that study were the monthly injectable.
So then going back to that slide, it sounds like they only got one injection.
Yes, that's exactly right. And that is often part of the real world, what we see. It's not to say it doesn't have a place. I think we were really excited to hear that we were going to develop a protocol for pharmacists for naltrexone. As I say here, there's no restrictions for prescribing it. It's not a controlled substance. It's an opioid antagonist, and it can be prescribed by any provider, including pharmacists can can use it under a collaborative practice agreement. It's very easy to use. However, it's only going to make a small dent, and that's why we really wanted to talk about some of the other ways. We're not saying that it shouldn't be used, it should be used, but the appropriate patient is going to be a very specific type of a patient, someone who's highly motivated, who is engaged in whatever the treatment is, whether they go to the pharmacy and have the pharmacist give them the injection, or the clinic, or whatever way that they, or a lot of these patients are also in the criminal justice system. So as long as you have someone that can continue. The other limitation is getting on it, because it requires a 7 to 10 day washout of opioids before you can go on it. It's an opioid antagonist. It blocks the opioid receptor. So if there are opioids there, you're going to go into withdrawal. And so the induction really is, that's the initiation of the naltrexone. You have to make sure there are no opioids on board. So that week to 10 days is a critical period where a lot of people fall out of treatment. So I have high dropout rate for the induction there in in one of the bigger...
They fall out before they even get the medication.
Before they get the medication. So it was like 28% versus 6% on buprenorphine. So you've lost almost a third of people. It's 6 times the rate of buprenorphine people lost to follow-up.
Question?
Yeah.
Yeah. After you have any data or any information after those people being rescued by the naltrexone, those people continue to abuse the drug, or what? Any statistic? Did they learn how to avoid it?
So the naltrexone isn't really a rescue in the sense here. I think you're thinking about naloxone, which is the rescue drug.
I'm sorry, the naloxone, yeah.
Yeah, and so these folks were people who had experienced overdose, but this wasn't necessarily immediately after overdose. So this is really, that's how they were included in the study, but this wasn't part of the rescue from overdose. This is just people with sort of the opioid use disorder.
But experience, I mean, you have any information? Are those people being rescued? Are they continue? I mean, did they learn from it, or did they just like nothing happened? But what we worry about that, I mean, they feel safe to abuse the drug because they know there's naloxone.
Yes. I think what you're speaking to is a really important part of managing patients with opioid use disorder. The dependence on the opioids is so strong for some people that people will do things they never imagined that they would do. And what you might think of on paper as a wake-up call, because I was just brought back from being blue and not breathing, might make some sense, knock some sense into you. It sounds right, but that's the power of the dependence to the opioids and the strength of the cravings, to realize that there are people who've had multiple emergency reversals. But what I always say is that you can't get a dead person into rehab, right? So you have to be able to be reversed to get into rehab. And it might take 1 time and it might take 10 times. But if that's your family member, then it doesn't matter how many times, as long as they're still around so that they can get to treatment. So what we're trying to do is make sure that treatment is available. Because the problem is that there are people who do want to get into treatment and it's not available, either because geographically, financially, or just logistically, it's not enough people are doing that. And that's what James is going to talk to. But I think the naltrexone is important. It's easy. It's easy for pharmacists to be involved. I think the next slide is really the pharmacist piece here. Pharmacists are currently administering naltrexone monthly injections, just like they're administering vaccines, just like they're administering long-acting injectable antipsychotics. There's no CPA required for that. There are CPAs that other states have developed. Massachusetts, Kentucky, South Carolina are examples. We could develop one for California just to give guidance to our pharmacists. But that is, there's no restriction to doing that. And in fact, there are a lot of resources and toolkits that can help educate pharmacists in naltrexone administration and being part of a CPA. And with that, I want to turn it over to James to talk about the other 2 modalities, the methadone and the buprenorphine.
Thank you, Talia. So we're going to move on to something that you guys have heard a lot about, which is methadone maintenance.
I have
This has been...
I have one question. before you move on,
Yeah.
with the 7 to 10 days, if the pharmacist is going to be taking care of this, are there tests, what we need to know for sure that it's been 7 to 10 days?
Yes, and so you'll see if you look at the CPAs for some of the other states, they specify in there that you'll do a COWS, which is an opioid withdrawal scale. So you score to see if somebody is having withdrawal symptoms. You give an oral dose, a small dose of oral naltrexone is one way to challenge to see if then an hour or two later they develop withdrawal symptoms. You also get verification verbally from them, and you also get a urine tox screen or an oral swab. So there are different ways to help assure that someone has withdrawn from the opioids, more than just they're saying that they have. And believe me, they're not going to want to lie about that, because they know that if they get naltrexone, they're going to get dope sick. They're going to go into withdrawal. Yeah.
And precipitated withdrawal is far worse than spontaneous withdrawal. It's much more severe.
It's just knocking those opiates off your receptors, and that's it. Doesn't feel good.
Okay. So methadone maintenance has been the gold standard for opioid addiction treatment for the last 60 years. It was first studied in the 60s by Dolan Niswander, who did a pilot study because they would detox people with agonists, who were using heroin, and they would go back to using heroin. And they went through this process a bunch of times. He said, what if we leave them on this medication? How are they going to do then? And it turns out their outcomes were phenomenal. They had a very small group. They kept tight control over them. They saw them daily for dosing, and they used less heroin. They injected less. They got arrested less often. They went back to work. They started enjoying life again. So they saw some really good outcomes with this early pilot. And for the next 5 or 6 years, that was the only place that we could offer methadone, was in these research settings across the country. By the early 70s, it was codified in the Narcotic Addict Treatment Act, which said we can do methadone under certain circumstances. And the circumstances were inside highly regulated opioid treatment programs, also known as narcotic treatment programs originally. And that's somewhat how it stands today, and it's unfortunate. We have a very effective drug that is so highly regulated that it's expensive, and it requires basically a building, a federal license, a state license, a DEA registration, a staffing ratio, and a lot of services, which are really quite fantastic, but you can see how that's not a very mobile service to deliver treatment. And this has been what we've relied on really from the beginning for opioid addiction treatment up until the most recent iteration. And in California, we have a fair number of methadone clinics. The unfortunate reality is they're not everywhere. As I mentioned, it's not a very mobile service. And you can see that the counties that have the highest overdose rates don't have methadone clinics. They tend to be built in cities. And cities have a lot of other services too. But our overdose rates are highest in the rural northern counties where methadone clinics aren't. About half of our counties in the state don't have a methadone clinic. We're working on that actively. I did highlight that there was a remote dispensary open in Reading, which will be a fully licensed OTP in short order. That's the first one to kind of invade this area of the state where we have such an outbreak in overdoses. So we're making some progress, but by and large, methadone clinics are not where people are dying from opioid overdoses. So how do pharmacists play into this? Well, methadone is something that comes out of these opioid treatment programs. It's a system of care, and pharmacists can be involved in the dispensing of it, of course, but also in the clinical management. This is a drug that has a narrow therapeutic window. It has a lot of drug interactions. It's pretty complicated in terms of how medications go. And I think pharmacists can have a lot of input on it from a clinical standpoint, but can we, walk in and operate a methadone clinic? No, it's not within our license capacity. We can participate in it. But one of the ways that we can be much more involved is by having pharmacies that are licensed OTPs. And this has been available to us in this country for almost 20 years, clearly. And to date, we only have a few pilot sites. We're guessing that there's probably less than 10 across the country. 2 of them are in California. So the idea is that we take the licensing and regulations of a methadone clinic and we put it in a community pharmacy. This isn't foreign to other countries who do this on a routine basis. Most of their opioid agonist treatments actually dispense from community pharmacies. But in this country, we put it all inside the walls of an OTP. Whereas you can have a pharmacy actually have a license to dispense methadone in collaboration with a community physician. This is a much more nimble activity. It has a lot fewer overhead costs, but we've had very limited uptake. Pharmacies and pharmacists have been shy to move in this direction, even though the exemptions and the licensing and everything permits it. It just hasn't happened, unfortunately. But I think there's a big gap here, because guess what all those counties have where we don't have methadone clinics? They all have pharmacies, right? That's where people are going already looking for care. So any one of them could actually be an OTP.
I've had a client who was located down the street from a methadone clinic, and it was pretty heavily traveled, the methadone clinic. I could kind of see why a pharmacy wouldn't want all those people coming into the pharmacy. So I think there has to be a better way to do it. Hopefully they can open more clinics. But I would think that it would be a deterrent to other customers of the pharmacy with all the addicts coming in for their methadone. So
Yeah, and that's a common concern. And
Right.
interestingly, when we started our pilot program in San Francisco, the patients that came to us wanted to move away from traditional OTPs because of some of those concerns. They were being hit up, in line, to buy crack and other drugs, and they didn't want to be part of the methadone clinic community. They didn't feel safe in it. So the pharmacy was actually the best part, was moving away from that. And what we're talking about is medicalizing treatment. Instead of putting it all in one place, it actually gets spread out so that you go to your primary care doctor who orders the methadone, and then you pick it up at your community pharmacy, just like your blood pressure medication. And this starts to reduce stigma, and it doesn't have everything that's tied to, an NTP or a methadone clinic.
So it's not like a big line of people.
Not at all.
going there, like-
Not at all. Not at all. And the DEA requires a separate dosing window. So there are some physical plant barriers to this that can be bypassed, but it's done in a very private, separate waiting area in the pharmacies that do it, and it doesn't look at all like a methadone clinic. The volume's very low. These are stable patients. That's part of, I think, what's different is the medical maintenance model is for patients who have been stabilized at an NTP, and they're getting monthly take-homes already. And they just want to get on with their life. They don't want to be tied to the rules and the regulations of showing up at one place for dosing. They want to get it from a pharmacy. So they come in once a month. They're highly stable, and they're very pleased with the process.
But of course, that's where there are methadone clinics in the area. So where there are none, and all you have are pharmacies, then they're going to get, the population that would have otherwise gone to the methadone clinics.
Yeah, and the reality is that they're in our pharmacies already. This is our patient population. They're people that have soft tissue infections and chronic diseases like hepatitis C that, we see every day.
Thank you.
All right. So the next drug I want to talk about is buprenorphine, and this is the one that's gotten the most attention, and it's because it's a lot more flexible. In 2000, the Drug Abuse Treatment Act said Schedule 3 through 5 opioids could be used to treat opioid addiction outside of an opioid treatment program if you meet special criteria. And the criteria were you had to be a physician, you had to go through an 8-hour training, and you had to have this thing called the X number. So there was a special DEA registration for it. Under all those criteria, a drug that fit that category could be prescribed. And this was the first time that we began expanding access to agonist treatment. just like methadone, the outcomes are phenomenal with this. I may not have highlighted it with methadone, but agonist treatment reduces overdose mortality, it reduces opioid use, it decreases criminality, it decreases injection drug use, infectious disease, everything that's associated with it. Both of these drugs have substantial data supporting their benefit. We do not have that with naltrexone. We just haven't studied it to that extent. We got 50 years of data with the other two drugs. And buprenorphine looks the same. The retention in treatment may not be as good as it is with methadone. One of the benefits of methadone is the high contact. You come in for dosing frequently, you get the wraparound services, and the withdrawal from methadone is more severe than it is for buprenorphine. So if a patient misses their dose of buprenorphine, they may not notice it for a few days, actually, and there's good and bad to that. The bad is that treatment retention is slightly less than it is for methadone. But we've been really blessed with the option of having this drug on the market since 2003 because it's really expanded our ability to treat opioid addiction. As I said, OTPs are a fairly fixed commodity, whereas a prescriber getting an authorization to prescribe this drug really is limited only to our supply of providers in this country. Originally, it was restricted to physicians. They could only do 30 the first year, 100 thereafter. More recently, as Debbie pointed out, we've expanded the authority to NPs and PAs through the CARA in 2017, and then in 2018, the Support Act added nurse midwives, nurse anesthetists, and clinical nurse specialists. So there's a lot of provider types that can do this, not pharmacists, unfortunately. So buprenorphine has really turned opioid addiction into something that is less stigmatized than methadone because of where it comes from. Primary care doctors have become the primary workforce for this in this state and in this country. Originally, it was mostly addiction medicine physicians, but it's moved out into primary care. So a lot of buprenorphine is happening in our primary care homes where people are getting all their other medical services met, and they're picking it up at community pharmacies. The distribution of buprenorphine waiver prescribers looks similar to methadone. It's mostly concentrated in urban areas. So we've had some uptake in the rural communities, but it hasn't been enough to address our need with opioid overdoses and opioid use disorder in those places. We have doubled the number of waivered providers in this state in the last 5 years. Since 2014, we're up to just over 6,000. Unfortunately, not all of them prescribe. In an early analysis, we found that almost 50% didn't prescribe any buprenorphine at all. So just having somebody with a buprenorphine waiver doesn't mean that they actually use it. So that's an untapped resource that I think we need to be aware of. But if you add everything up, if every provider in the state maxed out their capacity, we still couldn't treat everybody if they wanted it. So it's not enough. The average provider treats 9, by the way. So the actual capacity is far lower. It's probably less than half of what you see here, of about 300,000. But even if they treated every single patient up to their license, we wouldn't be able to treat the 350,000 people in the state. There's definitely a gap. So what do we do? So buprenorphine was an expansion of access to opioid addiction treatment, but it wasn't enough because we have this waiver requirement. And in France, they said any physician can prescribe buprenorphine or methadone, which are provided in community pharmacies, and their overdose rate dropped by 80%. So there's clearly some benefit to removing the regulations. I think it makes good sense on the federal level to add buprenorphine to the mid-level practitioner authority of a pharmacist. I feel like we're the only ones that were left out, and they keep adding more providers, but not us, unfortunately. And then there's this capacity for pharmacists to work through collaborative practice agreements. So even though we can't be the prescriber on record, this is a medication that I think was designed for pharmacists. This is an illness that responds extremely well to medications. We're talking about a drug use disorder with opioids. I don't think there's any profession that understands this better than we do. So we're in a great place to design induction protocols for buprenorphine to get patients on stable doses and to manage their comorbid conditions like psychiatric and medical that come along with not being in a medical setting for a long time. And we can do that through collaborative practice agreements, and there's some in existence in other states.
To kind of go back on and look at your first point there, removing regulations in France increased access and reduced overdose deaths by 80%. Now, what political or practical block is there to doing that here?
Well, it's federal.
Okay, it's federal, but is that why is it on the federal level blocked? Is there? I mean, it seems like the company would promote taking down the restrictions.
Well, let me start. The place that we started at was we're going to tiptoe into an area of treating this high-risk community for diversion with an opioid, and we're not going to watch them closely. So the DEA kept a very tight rein on that. And they even did inspections of providers. They wanted to see what was going on in their office, and they did chart reviews and everything. So we moved into this thinking this is methadone light. So the regulations have been loosening very slowly with a lot of caution because everybody thought this was going to blow up in our face and we were going to have a problem with buprenorphine diversion, which never happened. Along the way, we had a problem with opioid addiction, which did happen. So I think we just keep making steps down that way. And frankly, pharmacists haven't been looked at as part of the workforce from a prescriber standpoint. They know that we dispense buprenorphine, but we haven't been recognized as prescribers, I believe, in that capacity. And part of that's because across the country, not every state is as generous as California. And we haven't had a good voice. Okay, so what are we doing now? So currently, pharmacists can have a big role in buprenorphine treatment because these, unlike any other medication out there, buprenorphine is dispensed in short days supply, and this is a maintenance medication. There is nothing else that looks like buprenorphine. Commonly, we have patients on 7 days supply. So they go to the pharmacy, they see their pharmacist, they pick up their next 7 days of buprenorphine, and they come back 7 days later. And this is because we keep a fairly tight rein, particularly early in treatment. You know, it moves out after that, but there's no other drug. I mean, antibiotics are dispensed in short days supply, but you pick it up once, right? You don't keep going back to the pharmacy, but buprenorphine is different from that. So pharmacists have a big role in this. And unfortunately, they haven't always been warm and accepting of patients with opioid addiction. And there's been pharmacists that won't refuse to stock this medication because they don't want to treat those people. That's a direct quote from what I've heard. And when patients come in, they really are not welcomed into it. They're looked at as a burden, as a potential problem. It doesn't have to be like that. There are examples where pharmacists really do step forward and say, I'm going to be involved with your treatment with this medication. I'm going to check in with you. If something's not working out, I'm going to communicate with your provider because guess what? You see me more than anybody else, which is true. And there's several providers that rely on their pharmacists in this capacity. So having a warm, welcoming approach, having the medication on hand, patients come in withdrawal before they get their first dose. Like they show up looking sick. And if you don't have it on the shelf, they're going to walk out the door and buy heroin because that's what's going to make them feel better. And we need to intervene in that situation to make sure that it's readily available. There have been a lot of third-party payer restrictions on this medication. They have loosened up in the last few years, but that's been one of our issues, is that prior authorization is a death sentence for somebody that's an opioid withdrawal when they need the medication. So pharmacists would have to intervene under those circumstances. And again, there's a lot of case management that happens at the pharmacy level. So I think there's much that could be done. Supervised dosing is also part of this. So for patients that aren't doing as well, I may have them go to the pharmacy on a daily basis and take their dose under supervision, almost like they were in a methadone clinic, and that ensures that they're getting the medication that they need. And I get the information back about how they're doing. So that's a very high level of care that community pharmacies aren't used to, but I think it's appropriate and it's often needed, particularly in rural areas where we don't have access to methadone maintenance. So in the clinic setting, as I alluded to, we are restricted on prescribing buprenorphine, but pharmacists can play a big role in designing the regimens and monitoring for patient response and to see how they're doing, and also to follow up on all their other chronic medical needs, including chronic pain, which is very common, as Talia mentioned earlier. And there are CPAs that have been written in other states and pharmacists that are in the thick of this. But I believe pharmacists tend to be very conservative, and they don't want to participate in something they feel like they don't have any role in. And I think the board's in a position to say, yes, you can do this, and this is what it looks like, and provide clear guidance for them through an example collaborative practice agreement. All right, so what's missing? I think stigma within our profession is a big barrier to access to addiction treatment. You know, when somebody shows up looking for their buprenorphine prescription and they're told to go away and they're spoken to in a negative manner, you know, that's something that needs to change. We wouldn't deny medical care for any other condition. Why would we do it for opioid addiction? It really is beyond me. So we need to get past the stigma, and we need to tell pharmacists that this is what we do. This is healthcare, and this saves lives. And we need to make it a norm. I think we did a good job with naloxone in this country. We made it normal for pharmacists to participate in naloxone access, and also required it in some capacity in some states. We haven't gotten there with agonist treatment. It still holds a lot of stigma to it. So I think we need to move, you know, beyond the stigma and say, listen, this is part of what we do to take care of human beings. In the clinic setting, I think pharmacists do need some clear direction about what it is that they can do. Everybody that works with buprenorphine is afraid that, you know, we're outside of, you know, our DEA registration because it doesn't allow for us to do it. And it makes for a cumbersome system when you have to get oral, you know, verbal authorizations from the X-waiver prescriber in order to do a refill or to change a dose or anything. It's just not a very efficient system.
Question.
Yeah.
Do you know in those states that they are utilizing pharmacists, are those services being compensated or reimbursed?
They are, and it's mostly indirectly. So as ancillary to physician services, or it's in a closed system like the VA or in Kaiser, where pharmacists are on salary and they're, you know, it's a capitated reimbursement probably for all the services that are being provided. I'm not aware of any state that has a line item reimbursement for what they're doing. It's an ancillary service, yeah.
And just to close, these are just some quotes from leaders in pharmacy. There are many more that I could have put on there, but for readability, I limited it to some comments from AACP and ACCP and APHA. Recently, the National Academies of Medicine and Sciences put out a call for commitments from organizations, and over 100 have written commitments, including APHA and ASHP. And AACP, committing as an organization to work together and be part of the, you know, solution. And just in closing, pharmacists, as you all know, are uniquely poised to really make a difference. And really, parts of the things that we've already been doing are trying to be helpful in pain management, monitoring PDMP, offering ways and educating about proper disposal of opioids so that there's less misuse of them. And the naloxone, as James said, in less than 5 months, 1,400 pharmacists were trained through the board's webinar that we helped create. And so really we see the board's taking action on this is very promising, because this is the best way. We have all these organizations, but the board is really the best way to reach pharmacists. And in our work throughout the states over the last few years, pharmacists are interested. You know, there are pharmacists who say, I don't want those kind in my pharmacy, but especially in the rural areas where we were doing a lot of our naloxone work a couple of years ago, like James said, those patients are coming into the pharmacy. They're dealing with those patients and they want to be able to help them, but many of the pharmacists feel undertrained or there's a lot of misunderstanding about what they're allowed to do, not allowed to do. So having some guidance from the board would be really important. And I think for other states too, California's leadership really could become a model for other states as well. So the three key points we see is the naltrexone monthly administration in community pharmacies, as well as in collaborative practice agreements in clinics, pharmacies becoming licensed as NTPs for daily methadone or less frequent dosing, and buprenorphine CPAs either in clinics or in pharmacies.
You know, before you close up there, you say you'd like the board to help. Do you have a want list there?
Well, we were talking about that, and I think, naloxone is a perfect example. Having the protocol, having some guidance in terms of resources where pharmacists can look for very practical, how do I bill? How long do I keep records? So the very practical kinds of a guideline or an algorithm is very helpful. And just knowing that the board has endorsed this practice as part of pharmacy practice. So a CPA, so an example would be providing a CPA or passing along resources. A lot of resources already exist, as I showed for naltrexone, but also for buprenorphine and methadone, but offering those resources so pharmacists know where they can go.
I think pharmacists need to be given permission to do things that they weren't taught in school and isn't perceived to be the standard. So highlighting, these are the federal statutes that govern methadone maintenance. These are how you get the exemptions. And these are the examples of pharmacies that have already done this and gone through the process. Just putting it out there and saying this is a practice that you can do if you're interested in having this service in your community goes a long way.
And I think coming from an academic institution, I would also say, AACP has looked at substance use and provided some guidelines about how it's incorporated into our curricula. And they've suggested that there be at least 4 hours of pharmacotherapy on substance use disorders provided. Now, I know that there's a great range in the number of hours that are provided at the various programs, but if the board could even say, to the schools, it would be great if you had some sort of minimum number of hours devoted because you're championing some of these initiatives.
Okay.
Thank you very much, you guys, for coming back, because I know we took quite a bit of your time last time, and I know, Taya, you have to come up from Southern Cal.
Happy to be here, yeah.
So you mentioned your curriculum and the board suggesting to the schools about your curriculum, which I don't think we do successfully. And so given that point, what are the schools doing? I mean, it seems to me it's the chicken and the egg story. So how are the schools educating these new pharmacists in either the disorder or addiction, whatever you want to call it, and how to deal with it as professionals?
I think we're improving. I went to school in the Stone Ages, and it was a lot less than what I provide my students now. And I was part of an AACP environmental scan for opioid related activities for all the 100 and whatever, you would know better than me, 14 or whatever it is now, this week, a number of schools in the country. And there is a range, but I think it's increased and improving the number of opportunities for students in service, in research, and certainly in education around substance use disorders. So it's of great interest to AACP as well. And I think the deans are very interested also. In California, after the legislation went through and the protocol came, I think the deans, and I think it was nationwide actually, but it coincided with when California had the naloxone protocol, all the deans signed an AACP commitment that they would involve opioid overdose and naloxone training in their program in some way.
Do you concur, James?
I do.
So now currently, I think all of the schools of California, the students are graduating ready to furnish naloxone, that they don't need the CE, that they've gotten at least that component in school. But now we want to make sure they get more than that.
I think our challenge is there's not enough pharmacists that specialize in this area to provide the training across schools of pharmacy. And we were at this point with psychiatric pharmacy not too long ago, where we had a specialty that we wanted every pharmacist to be competent in, but not every school of pharmacy had that person to teach them. And when we break it down on the curriculum basis, there's not enough time devoted to it. I did a couple hours in OUD at UCSF for many years. Is that enough to learn how to do this in a competent way for a graduate? I don't think so. There's a lot that can be picked up on. I'm not saying it's complicated, but in order for pharmacists to be comfortable with it, it takes more time, and it should be, baked into the curriculum, as this is an important chronic disease like diabetes and dyslipidemia. This is something that you can do. This is something that you should be a part of. That's the message, and that starts to erode some of the stigma too when they see it as a core principle in their curriculum. So there's a lot of benefits to it, but we have to have the pharmacist leaders to step up and do it.
Thank you.
So once again, the committee appreciated, what the information they provided. We got some feedback from other people in the audience. So what we decided that we needed to do is hone in on 4052, which, if you're familiar with that section, that's a section where, like, emergency contraception, nicotine replacement, that perhaps we needed to add a protocol in there, just like emergency contraception, nicotine replacement, around naltrexone, similar to what Kentucky has done. We also, we decided that there needed to be a three-prong approach. Number one was to get approval from the board to move forward with proposed statutory language around 4052, adding it as section 14 that would say provide non-opioid medication assisted treatment pursuant to state protocol. And so the licensing committee would take that and develop a protocol, probably based on what Kentucky did. And if you go into your attachment, you can see Kentucky's protocol there, which is pretty complete. And that's probably where we would start. Not sure we would do exactly everything that they did, but I think, that's a great place to start. Second is encourage pharmacists to become licensed as OTPs for methadone dosing. And third, to direct the licensing committee to work on collaborative practice agreements for pharmacists so they could work with prescribers who have the DATA 2000 waivers so that they could administer buprenorphine. So that's kind of the three-prong approach that the committee came up with. And so the committee motion was to approve proposed statutory language to amend BPC 4052 to add subdivision A14 to direct staff to secure an author to sponsor statutory change, and then also direct the licensing committee to move forward with the second parts 2 and 3 of the committee's recommendation. Once again, the language specifically that we're talking about adding in 4052 A14 is to provide a non-opioid medication-assisted treatment pursuant to state protocol. So first, going after the naltrexone, and then, over time, trying to, get collaborative practice and buprenorphine and then also even methadone-type clinics.
Okay, so
and
is
if you remember,
is that the committee recommendation?
yeah. And I just want to remind you that back in January, the board did vote on a policy around, having pharmacists added to potentially that DATA 2000 waiver, kind of try to use our muscle on the national stage. But for now, this is what the committee is motioning.
Okay.
Before you go on, can I ask or make one clarification? Because when I was preparing for today's meeting, I noticed that the Kentucky model does actually have a prescriber authorizing it, but my understanding that the committee is seeking is basically that this would be something that the pharmacist could do independently.
Correct.
Same
We
way it
would
does.
do a protocol.
Right.
So we would not need that. So the council's getting into some of the details of the Kentucky program that we would probably not do. If you looked at the Kentucky program, there was a prescriber would sign off at the top. There's some sort of a little log that you did the training. Obviously, you would have to do the training just like we do with our other programs, but we would envision at this point in time that that's probably one of the things from the Kentucky program that we would not pursue. That each one would have to have a physician sign off.
Right.
Okay, so we have a committee recommendations. Any other comments from board members? Any public comments? Danny?
Good afternoon, board members. Danny Martinez with the California Pharmacists Association. We support this concept, and the only thing I would add is as we move forward with allowing for an expansion of pharmacist services, that the board also consider adding adequate compensation. I know that it's been a barrier to a lot of pharmacist services being provided in California. So as we've been doing with other pharmacist services, mentioned, the naloxone, the other services that are currently, we have payment in place right now under Medi-Cal, and that's actually what's driving a lot of interest in providing those services right now. So we would ask that the board also consider adding a payment component to this as well.
You know, I've got a question about that.
Yes.
Now, and while I'm certainly in favor of it, and I think, just practically, you need compensation to make this occur.
I would hope so,
okay,
yes.
Yeah. But is that in our purview?
I don't think so.
Yeah,
But could we get whoever takes whoever we move to do the statute, we can always have them put it in, but it's really probably not part of our.
If it's your sponsored legislation, and Laura can correct me if I'm wrong, you can put whatever you want in that legislation, in your sponsored legislation. Would it be under the? I don't believe it'd be under the board or the Business and Professions Code. I believe it'd be under Welfare and Institutions Code for payment under Medi-Cal. But it's certainly you have that luxury of whatever you want to add in your.
Well,
your sponsored
luxuries I like.
And I think, Danny, you're saying the same thing as me. It's our bill. We can ask the author to include it, but I don't think payment is part of our, we're about the safety of the consumer in California.
That's fine. I'm just
But
saying.
I think we're saying the same thing, is that we can encourage the author to include that.
Great. Thank you.
Go ahead.
Hi, good afternoon, members of the board. My name is Samantha Pion. I'm with the California Medical Association. I just want to provide a few comments and background. CMA has been heavily engaged on this issue for quite a while, and we've advocated for a balanced and broad approach to prescribing, to pain treatment. And we've been involved in efforts to increase access to medication-assisted treatment at both the state and federal levels. CMA also recognizes the important role that pharmacists play, and we support collaboration with pharmacists as valued members of the care team. With that said, we do have serious concerns with the proposal to amend the law that would permit pharmacists to provide medication-assisted treatment to patients with substance use disorders. Such medications must be part of a broader treatment plan that includes behavioral therapy and ongoing monitoring. Furthermore, while naltrexone may be as good for people who have successfully completed the detoxification, research indicates that relapse is more likely with naltrexone versus buprenorphine. And so as a result, we're concerned that statutorily advancing a treatment approach may encourage uptake over other treatment options that are not available to pharmacists due to federal law. Additionally, as the proposal is currently worded, it does not include many of the same statutory protections in place that have been done with other authorized procedures, such as nicotine replacement therapy and, as was mentioned, naloxone. As written, we are opposed to this motion, but we welcome the opportunity to engage in further discussions on how we can meaningfully increase access to patients with opioid use disorder.
Can you clarify what you mean by nicotine replacement has some statutory protections that this wouldn't have? Because it is in the same
naloxone as
DMP
well. Code. Yeah. So if you look at it in the, it should have its own section, and maybe I'm confusing with naloxone, but
nicotine
it has its
replacement
own recommendation, has its own requirements in terms of training in statute. Other requirements in terms of making sure that there's communication with the treating prescriber. So there's coordinated care, and there are other additional elements in there that are in statute and follow the different scope of
Did you
practice.
look at the Kentucky law? Because
I did, yes, yeah.
The very first paragraph of the Kentucky
Right.
law is about the training piece.
Sure, but that's not what's before us. It's the statutory proposal, which doesn't have any of those same elements in there.
Well, but I think what we're proposing is a protocol. So you're looking at one sentence, and the word protocol, then is what is that 3 or 4 pages that is the Kentucky. So you're looking at one sentence, you're not talking about the 4 or 5 pages.
Well,
that
the one
protocol- Excuse me,
sentence.
can I just finish? So it says provide non-opioid medicated assistant program pursuant to a state protocol. The state protocol would include the training, what the in fact, we can go through the Kentucky protocol, but it has the training, it has, the steps that the pharmacists take. As with our other protocols, we normally have always communicated back with the primary care if we know them. So I don't think that our protocol on this would deviate from the other protocols that we've put together in the past.
Well, it would in the sense that you had also mentioned earlier in the meeting that you'd be able to initiate for medication-assisted treatment. But as other scope expansions have happened around naloxone, the language has usually followed a standardized format, and it's include other boards as relevant, like the medical board, and that has been in statute. So that's typically the model that we followed. And so looking at that, we didn't see those same types of protections.
Yeah, I think that, this is just one sentence. I don't think we have the statute here.
Okay. Well, we're open to, having further discussions, and to the extent that we can work with you guys and discuss this further, we'd love to.
Yeah, I think the pharmacy board always wants to cooperate with the medical board.
Right.
And I hope vice versa.
Sure.
Vice versa, did I say that right? Or did I say versa versa?
Either way is okay.
Oh, CMA, okay.
I think, with regards to the medical board, in the past, we have had collaborative relationships with them regarding other medications that pharmacists are able to dispense. Birth control pills is a classic example of that. And for whatever reason, there's always been resistance, and then dialogue, and then collaboration. But certainly you can't question the knowledge and ability of a pharmacist when it comes to these drugs, and the training that probably is going to evolve from the schools. The pharmacist is in contact with these people all the time, and as it was said earlier, I don't know, were you here for the presentation that showed
yes.
how few physicians see these patients and how few patients they see?
So I would push back against that a little bit.
This would be access to programs that are available, but there's no access for whatever reason.
So I'd push back against that a little bit, and I just want to mention the hub and spoke model, which Department of Healthcare Services has been doing. There's been really great recent data to show there's been an uptake in prescribers who offer buprenorphine, and that's really great news. I think we recognize that this is as was mentioned, a high-risk, complex patient population, and delivering something like naltrexone, which is, as was stated earlier, has to have, a person who is, highly motivated to do it. The relapse rate is higher than buprenorphine. We just want to make sure that there's some kind of, coordination with a physician with medical practice at some point.
I think the pharmacy board has always been sensitive to that issue. However, we are a consumer protection agency, and we are here for the public and for the benefit of the public and the health care of the public. And access in so many things is critical. And we have pharmacies, so prevalent in the communities, and the availability sometimes is so much better than a patient trying to find a physician or a physician's assistant or a nurse practitioner to treat their problems.
Right. And we've been open to other discussions in the past, as was mentioned, around naloxone, and see the value in something like naloxone, which is immediately effective. So like I said, we'd be interested in continuing those conversations.
Thank you for your comment.
Thank you.
Any other public comment? If not, let's call for the vote. All those in favor of the recommendation, please raise your hand. Oppose, abstain, and the motion carry. Debbie, could we take a 10 minutes break?
Absolutely.
All right, let's take a 10 minutes break before we continue.
Good job, Debbie.